But anyways, my name is Samir Bidnur. I'm a PGY2 in the Department of Urology. I'm looking to speak today about ureteral stents, some of the common and not so common complications that are associated with them, as well as some of the new innovations that are making them broadening their indications and improving their morbidity factors. For today's talk, I'll have a brief introduction about ureteral stents, and then I'll focus on reviewing some of the complications here, focusing on some of the bothersome symptoms which are quite common with stenting, as well as some of the rare complications like ureteric arterial fistulas. I'll also go over stent-associated infections as well as stent incrustation and the challenge that can be presented to the urologist in the forgotten stent, which can become quite calcified and difficult to retrieve. We'll then go over some of the technological innovations in the field of ureteral stenting, including a new stent registry, which enables the physician to follow the stents that are placed in order to not have the situation of a forgotten stent with the morbidity associated with that, as well as some new stent biomaterials. And I'm fortunate to have Dr. Lange from the Stone Center here offering to speak a few words on some of the new innovations that are coming out of UBC, including the dissolvable stent as well as the microstent. We'll begin with the introduction. The contemporary design for the double J indwelling stent was originally proposed in the late 70s with many modifications, but the double J stent as we know it today was described by Finney in 1978. Since that time, the indications for stents to relieve ureteral obstructions have expanded as the technologies available to the urologist have expanded as well, and include now the relief of benign and malignant obstruction, as an adjunct to stone therapy in both S-wall ureteroscopy and percutaneous nephrolithotomy, as well as perioperative placement for correction of certain congenital factors, for example, like UPJ obstruction, and as well the management of urinary leak to repair fistula, for example. The stent has now proven to be a key tool that all urologists use almost in every practicing domain within urology, and thus an understanding of some of the complications and their management is definitely warranted. So the first set of complications from the ureteral stent are the most common that I'd like to go over, and those are classified as the bothersome symptoms and are generally referred to as the pain, the dysuria, the lower urinary tract symptoms that are associated with stenting. So stent pain is very prevalent and can occur in up to 80% of patients and is experienced in very different ways. Some patients experience limited ability to work, sexual dysfunction, as well as some of the classic complications that we're familiar with, such as pain, both in the flank pain, suprapubic pain, and genital pain, as well as irritative voiding symptoms that are well described to be associated with stenting. More recently, Joshi et al. In 2003 developed a USSQ, which is the Ureteral Stent Symptom Questionnaire, in order to quantify stent pain to give us more ability to study the effects of stent innovations on stent-related pain. So we know that ureteral stenting affects the common urologic complaints, which are lower urinary tract symptoms as well as pain. But as well, Joshi et al.'s symptom score here broadened the spectrum of morbidity associated with the stent to include more broad parameters of global health, like general health and work performance and sexual matters. Their study included 309 patients in total across 3 phases to develop this validated questionnaire. And through their review process, they identified the 6 key domains of health which they wanted to include in their questionnaire. And those are described right here as the common ones: the urinary symptom index, the pain symptom index, as well as the global dysfunction that's associated with both acute and chronic stenting. There's also sexual matters, and there's one final parameter on other effects, which is not quantified here. They validated their scale across several groups: the group that was stented, the control group, A group that had urolithiasis but did not require any stenting or did not undergo any stent procedures, as well as patients that had ongoing lower urinary tract symptoms from another source that didn't require a stent, such as chronic prostatitis, etc. And they validated their scale through this population. Patients also served as their own control as they administered their questionnaire at week 1 and week 4 being their main key point, as well as post-stenting in order to see where each patient's baseline lies. And the scale was significant in assessing the differences in stenting in those the 5 domains that they described. This scale has been used consequently in other studies, mostly in some of the studies of stent innovations, where this is now a validated questionnaire in order to determine whether certain modifications on stent bear any clinical benefit to the patient. Gianni et al. Had a recent study where they also used this stent questionnaire and tried to correlate it with other parameters that may be more available to the urologist. And interestingly, one of the indicators that correlated well with the USSQ scores and all the parameters was the position of the stent location, particularly if it crossed the midline. This has been described in other studies as well as being associated with increased analgesic use and increased pain, but here was also connected to the USSQ as well. And the location of the distal loop, particularly crossing the midline, was also associated with increased analgesic use. And so this is becoming a very useful parameter as well in order to determine stent pain. Further studies on the treatment of stent-related pain, the pharmacotherapy for stent-related pain, have also used this validated USSQ in order to determine the effect primarily of alpha blockers on stent-related symptoms as determined by the USSQ. And several studies have looked at this, focusing on alfuzosin and tamsulosin. Interestingly, many of these studies, particularly Damiano et al. And Wang et al., found that the alpha blockers had a significant early effect on stent pain at week 1 when the USSQ was administered, and later on the effect was not as pronounced. This is reflected here in Damiano's study, where 75 patients that required ureteral stenting for non-malignant ureteral obstruction underwent the questionnaire at week 1 and week 4, where week 1 there's a significant difference between the placebo group and the alpha blocker group, whereas by week 4 there was no significant difference between the groups in the measured outcomes. A summary of bothersome symptoms. These are very prevalent. Patients that are stented will very likely have symptoms related to the stenting, and it does expand beyond the classic symptoms that have generally been attributed to stenting, significantly so, in fact. And alpha blockade in recent studies using validated stent symptom scores have shown benefit. However, routine use of alpha blockade after uncomplicated ureteral stenting is still not widely adopted for whatever reason. The next complication is one that's an extension of the general hematuria that most patients get, and is a very rare complication with about 150 described cases in the literature, but it's quite a devastating complication. Hematuria is very much associated with the procedures that require stenting as well as stenting itself. So microscopic and even small macroscopic hematuria is usually present but self-limited. But persistent and significant bleeding after prolonged stenting may be associated with the presence of a ureteric arterial fistula, which is one of the urologic emergencies that does not get much attention. Radiographically, on an angiogram, one of the classic signs is a pseudoaneurysm at the site where the stent crosses the vessel in question. And as well, we can see reflux of some dye going into the ureter. Once again, this is a very rare complication with a significant mortality rate dependent on the severity of the fistula. Oftentimes, its classic presentation is massive hematuria from a single ureteral orifice at the time of stent change, which is when there's disruption of the clot plug that's blocking the fistula. There are many risk factors for ureteric arterial fistula, and these include previous surgery, especially previous surgery for malignancy requiring radiation therapy. Underlying vascular disease is also commonly involved in this entity, particularly iliac pseudoaneurysms. And finally, chronic stenting has been identified in the literature as one of the most commonly associated findings or risk factors for a fistula. Again, the most common artery to be involved is the external iliac artery, but it can involve the aorta or the internal iliac depending on the position or the nature of where the radiation was, where the surgery took place, etc. Once again, the classic description that's described in the literature is pulsatile blood from one of the ureteral orifices and requires prompt recognition and prompt diagnosis and management. One of the recent reviews of some of the cases of ureteric arterial fistula by Bergovitz identified 42 patients that had some type of urinary diversion in association with an underlying vascular history or a vascular procedure or a sole urinary procedure with no underlying vascular disease. Again, in the exact area where the ureter crosses over the artery, there is a clot plug that presents there, which is why it is quite common for it to present at stent changes when the clot is disrupted. Diagnosis is done predominantly with selective angiography, although the sensitivity here is quite low, but there are not too many better studies. And there's a pseudoaneurysm that can be seen at the site of the stent crossing, and this is often not seen, and some authors suggest provocative maneuvers, which is direct manipulation of the stent while doing angiographic studies in order to identify the fistula promptly while having the resources for management of the fistula available right away. Cysto and retrograde pyelogram has also been described, but its sensitivity is also lacking here, again because of the presence of that plug that distorts the ability to visualize the fistula on radiologic imaging. Here again we see an angiogram of the iliac vessel that shows contrast leaking into a ureter, and on a delayed imaging we see the contrast accumulating here, and this is in a ileal conduit, and this is post-operation for bladder cancer, which also required radiation in this case. There's no consensus on the best treatment option for a ureteric arterial fistula, but the ureter and artery both require intervention. Typically what's described in the literature is endovascular stenting of the vessel involved, usually the iliac artery, as well as urinary diversion. You can see here, between here where we see the contrast going up the ureter, which is full of clot with the filling defects, after stenting of that artery and urinary diversion, the communication is no longer present. But again, this is a rare entity, and long-term outcomes are lacking, and patients in this situation usually do pass from another cause. In summary, hematuria related to stenting is very common once again, and usually of no clinical significance, but a ureteric arterial fistula is one of the rare and devastating consequences that can be associated with long-term stenting in high-risk patients, with controversial treatment, which usually is required to be multimodal in order to control the hemorrhage. The stent-associated infection is a very common consequence of stenting, and occurs, as you can see, 22 to 34% of cases despite prophylactic antibiotics at the time of stent insertion. And this number quoted here is in patients that had a negative urine culture at the time of the initial stent insertion. Negative urine culture in the presence of a stent does not rule out infection or infection symptoms that can be due to stent colonization. And in fact, we'll look at this in more detail soon. The duration of dwell time in the individual significantly affects the rate of bacteria, and is one of the most significant predictors of the growth of bacteria on the stent. One study that was done recently with 65 patients that had a urine culture done both pre and post stenting showed that stent colonization is almost universal. 64 or 65 patients in this study had stent cultures that were positive for an organism, whereas patients at the time of stent removal, only 17 of 65 actually had a urine positivity, on a urine culture positivity. And only in 10 of those cases were the urine culture and the stent culture the same organism. Again, the fact that the time of dwell of the catheter was significantly associated with the urine culture positivity. You can see if greater than 90 days of stenting, there's almost 50% chance that the stent will be colonized. In the study by Klissier, they didn't see any significant relationship between the urine culture and gender, diabetes, or the indication for stent, be it a malignant or benign obstruction. From this same study, the stent cultures revealed a host of organisms, mostly staph species and Enterococcus species. There's more below that are just one or two. But these are quite different from the urine cultures, which grew only in this study. The three organisms that were grown were E. coli, Staph epidermidis, and Staph aureus. So there can be quite a disparity between the colonized stent environment and the bacteria that are growing within the urine itself. Another study done by Kahinde et al. In the Journal of Urology with 250 patients also looked at dwell time with relation to stent colonization. They also focused on systemic diseases, particularly diabetes mellitus, as well as chronic kidney failure secondary to diabetic nephropathy, and also found that there's a significant amount of patients that had these chronic systemic diseases that did have stent colonization. And in their study as well, sex was strongly significant between men and women in regards to urine culture positivity, which is actually to be expected because obviously the women have shorter urethras and are more highly likely to have bacterial presence, which can then adhere to an environment that is that allows its growth, such as a encrusted stent. In summary, then, ureteric stenting is associated with colonization of variable organisms that can and often are different from the urine culture positivity. And negative urine culture does not exclude the fact that there can be several and many indwelling species on a stent, especially in the setting of individuals with chronic diseases, particularly chronic kidney disease and diabetic nephropathy. And once again, these studies, as well as several others, reiterate that stent time, dwell time, is significantly associated with stent colonization. Obviously, dwell time is also associated with stent incrustation, and that's the next topic here. The incrustation of the stent is a very natural process, which has been well described in vitro studies, but is very challenging for the urologist. And as we know, it's associated with prolonged dwell time as well as a history of urolithiasis. They describe lithogenic urine, which has a very high rate of incrustation on certain stent types. There's also metabolic and congenital abnormalities, history of chemotherapy, renal failure as shown in previous studies, presence of bacteria as well as pregnancy for the fact that it increases bacteria and calciuria as well. Lead to increase in rate of stent incrustation and increasing rate of stent failure as consequence. Essentially, no stent is inert within the urinary tract, and this is one of the key focuses on stent innovations in terms of engineering stents that have a better profile to engender less incrustation and less bacterial colonization. Incrustation of the stent is a natural consequence, as I said, of the environment, of the urine environment that the stent is within, and is secondary to initially protein absorption onto the biomaterial of the stent. In most cases, and in many cases that have been used for classic studies, it's the urethane stent that is used. Obviously, it's dependent on the nature of the urine and several of the risk factors that's described before, but many of the bacterial byproducts are able to deposit on the protein substrate, which forms on that on the stent, which forms a conditioning film, and that allows bacteria, which are normally free within the urine, to approach and then attach and become engaged and locked within that matrix and form what is called the biofilm of the stent, which then is a self-propagating phenomenon which promotes crystallization of particles and therefore incrustation and eventually stent failure. Again, several studies have shown that the time for incrustation is very closely dependent on the dwell time of the stent. And in cases of patients with lithogenic urine, that's even more pronounced, where in the study by Alpha Key quite a while ago, they showed that not only 10% of stents had evidence of incrustation on them under 6 weeks, if they were changed under 6 weeks of time, whereas over 50% of stents were encrusted when you go beyond the 6-week time frame, and obviously more so beyond 12 weeks. Incrustation in these studies is shown to occur predominantly at the tips of the stent, either the proximal or distal end, and it's said that in the literature that the ureter is relatively spared from incrustation secondary to peristaltic wiping of the ureter by the stent, by the ureter. And obviously, with the increased dwell time, especially in the case of the forgotten stent, the types of therapies that would be warranted to remove both the stone associated with the stent and the stent itself may require several procedures and several modes of therapy. So there's been a recently described shorthand annotation to describe the forgotten stent, which is referred to as the FEC-cal, which is the forgotten, encrusted, and calcified stent. This was described by Acosta and Miranda et al., and they described the following grading system. And they use this grading system to determine the appropriate type of modality that would be warranted to treat that type of stent. In their study, they saw only grade 5 calcification, which is thorough calcification of the entire stent, with stents that were indwelling for greater than 2 years. This was an example of one of their grade 1 calcifications prior to and post-stent removal. And it's a very nice image of post-stent removal, the cast of the proximal tip left in the collecting system, which could be treated with S-wall in a single sitting.
You know, if you go back, the neat thing about that is how did they get that stent out with just that perfect curl just sliding right off? Often
Yeah.
those stents won't even uncoil. I don't know if anyone else has seen that before.
Mm-hmm.
Pull hard. Yeah, that's a good idea.
And this is an example of one of their grade 5 calcifications, which was also in this case associated with obstruction and quite a large bladder calculus. So they propose an algorithm to determine the appropriate therapy, and it's initially based on the grading system. If the stent is encrusted grade 4 or 5, which is significant incrustation of both the proximal and distal ends, and including the stent body in grade 5, that the patients may be warranted to have a nuclear renal scan to determine functionality of that kidney prior to any stent removal therapy. Other indications that have come from this algorithm is also on imaging if there is poor parenchyma or evidence of renal long-term renal damage like scarring, that the individual also undergo renogram to determine whether the stent is salvageable, whether an open procedure is more warranted. In this study, they suggest that grade 1, 2, and 3 are treated usually in separate sittings, again, if the distal and the proximal loop are involved, either by PNL and then the bladder end by cystolithopaxy. This can usually be done in one anesthetic sitting, but sometimes for whatever reason, prolonged stone removal time, prolonged operative time, etc., there are multiple sittings that are required. This is just the end of their table showing the grade 4 and grade 5 stenting, which they comment does often require multiple procedures, and an average of 2 to 3 throughout the literature has been described. Lange described treating the distal component prior to flipping the patient and doing the proximal PNL in order to lessen the number of procedures, as it had the ability to loosen the stent and loosen the amount of distal stone burden, which is usually greater in the retained stent, as we've seen on some of the images here. And again, the need to do the renogram is quite poignant, as there's some individuals in their study that had a renogram just after 2 to 3 years of a retained stent, and it did show loss of renal function, and those patients were better served with a nephroureterectomy and open cystolithotomy for removal of the disease segment. We also recently had a case here at Vancouver General Hospital of a retained stent, which was, throughout the literature, one of the longest indwelling stents that have been described. And it was 12 years that the patient had forgotten about the stent, and he was otherwise relatively, living his life relatively well, but over the past year or two prior to presentation, he was having symptoms related to stent pain, which he had described. And the most significant symptom he described was poor quality of life, which is again captured by that stent questionnaire. He had a large 4-centimeter bladder calculus associated with the distal end of the stent, as well as a proximal stone associated as well, and multiple stones along the course of the stent as well. Interestingly enough, the stone over here is the original stone that he presented with, for which he was stented for, and it was still in place.
But it's quite amazing his whole length. I mean, usually when they're after 10 years or so, usually you see the grade 5 kind where it's like a huge golf ball up there and the whole length gets calcified too.
Yeah.
And he didn't have that.
And he also had preserved renal parenchyma. We didn't do a renogram, but he had preserved renal parenchyma on CT scan, and as well as normal blood work. And this patient required multiple therapies as well, including PNL and ureteroscopy and cystolithopaxy. The ureteric stone was actually left after the first procedure, and we attempted to retrieve it with S-wall, but the stone was too difficult, and a third procedure with ureteroscopy was required in his case. In summary here, the stent incrustation is a very natural and almost inevitable reaction between the biomaterial and the urinary environment, and is quite a focus in stent innovation and future designs. The degree of incrustation is related to dwell time, and this has been well shown in studies. And the forgotten stent, with especially when it's over 2 years and there's quite a bit of incrustation and impaction of the stent, is a very technical challenge for the urologist, and very often multimodal therapy is required. I'd now like to move on and briefly describe some of the innovations that are present in urologic stenting. One of which is the stent registry, which isn't an actual modification of the stent itself, but it's more so an ability to track the stent over time. Obviously, the reason these systems have been adopted and are becoming more so adopted across different institutions is that the forgotten stent presents, as we said, a very major challenge, and is a major patient safety issue as well. And there have been described paper-based tracking systems that have been around for several years that have had decent abilities to follow stents. However, they required quite a bit of active surveillance, as it were, by the urologist to ensure that they were keeping track of their own paperwork, which is difficult, understandably. This study here by Lange et al. Investigated computer-based barcode acquisition systems to make tracking of the stents much more rapid and much more easy. And their institution were previously using paper barcode systems, and were capturing roughly 61% of stents on their electronic system. And after their barcode implementation, they were capturing, in the 7 months post-barcode implementation, they were capturing significantly more of their stent cases, and were not missing as many stents, and therefore the chance of the forgotten ureteral stent is greatly reduced in their situation. Their algorithm is very simple and is a computer-based system that was adopted into their EMR. So if it's possible for PCIS or Accuro to have a system like this, it would be very likely beneficial. And it's just a very simple surgeon-guided program where the surgeon puts in a stent episode at the time of stent change or stent insertion and determines the maximum stent life based on the patient's history, the risk factors, and the indication for the stent, and then books a follow-up appointment, and the computer then reminds the surgeon 2 weeks prior to that maximum stent life date that removal is necessary, and continues to remind with daily emails and notifications. And in the Lynch study, the mean delay post the maximum stent life was only 20 days when they implemented the computer-based system. And finally, I'll just touch on some of the new stent biomaterials. There's a lot of new technologies that are being investigated currently for all of these morbidities that are well described and associated with stenting. You know, the ideal stent, if it were to exist, would be biocompatible with human tissues, but resistant to incrustation and bacterial colonization. Obviously, it needs to be radio-opaque for non-invasive identification, and it needs to do its job in relieving the luminal obstruction, and as well cause the patient minimal discomfort. This is quite a few things to ask of a stent, and currently the research is moving very vigorously towards that direction. Original stent materials were described using silicone, which failed as a regular stent because of its high frictional coefficient. Polyethylene was one of the substances that replaced it. However, it was very easy to fracture and encrust and was not used for any prolonged dwell times. And currently, since the 1980s, there have been polyurethane and modified polyurethane stent types that have been used. Once again, these stents have a very good mechanical profile, but they are prone to incrustation. And again, I'll point out that stent in the case that we had, that was there for over a decade, had not fractured and was a polyurethane stent. Urethane is a backbone that's linked by carbamate, and it possesses a very high drainage capacity, and the current stents do have metal wires that pass through them to give them more axial strength as well. The very common uropathogens that were grown on many of these stent cultures are known to adhere to polyurethane, which is why it has a shorter time to incrustation. But as mentioned, the tensile strength of this material, especially when reinforced with the metal in the stent, is quite favorable. And several studies using explanted stents have studied their tensile strength and showed that they maintain their mechanical properties even after their set dwell time. And currently, polyurethane, there's much research going on modifications of it, both in coatings on the stent itself as well as blending it with different types of polymers. I'd briefly just go over some of the surface coatings, and then move on to some of the new types of stents that are being designed, and here with Dr. Chu and Dr. Lange here in Vancouver. Some of the coatings that are commonly used, and the research, the trials on these are somewhat lacking in terms of being good randomized control trials. But there's several types that have looked at hyaluronic acid, heparin, PVP, and silver and diamond-like coatings. The indication for these stents, the reason these coatings are used is to reduce the ability of biofilm formation by preventing one of the key steps in the formation of either the conditioning film or the initial protein adsorption to the stent, in order to prevent that feedback cycle of incrustation. Silver and diamond-like carbon coatings are antimicrobial, and heparin and hyaluronic acid are very negatively charged and prevent the deposition of some of the crystalline cations onto the stent surface itself. Modified polymers are another big area now of research, of blending polyurethane with other substances that can lend the stent different properties, either different properties in regards to how cations bind to the stent surface, or also modifying the tensile strength and the ability of the stent to maintain its shape in vitro and in vivo. But right now, I'd like to move on to some of the newest type of research that's moving on in this field, and that's the biodegradable stents that are being engineered here. And I'd invite Dr. Lange here up to mention a few words on the biodegradable stent and some other stent technologies. Switch it.
He'll do it for us. Excellent. Thanks very much, Samir. That was a great summary of some of the stent-associated problems. I'm just going to take a few minutes to talk to you about some of the novel stent technologies that Ben and myself have been working on and have pretty much or are seeing through since their infancy, and I'm going to focus on the micro stent as well as the biodegradable stent. And just for those residents and fellows in the room, you are expected to memorize all the algorithms that Samir was talking about, especially the incrustation one. And there will be an exam on that later on this week. So let's talk about the micro stent. And this stent kind of moves away of the normal convention of the double J stent in that it consists of a novel 3 French cannula. It doesn't have a central opening. It does still have a distal bladder anchoring coil, but it has this novel film component that anchors it just proximal to the stone. And the film component does have holes in it to facilitate urinary drainage. I have a couple of videos here. Show you this one where the stone is in place, and that stone is a ball bearing, but oh, sorry, go back. So you'll see the microstent inserted here, and it's actually quite interesting because the film anchor is very lubricious, especially when it gets wet, and it essentially slips right past the obstruction. And then you just pull on the guide wire and essentially deploy this film anchor. There you go, now you can see it deployed. Almost forms like a butterfly type shape as it's deployed as well. And you just pull out the wire there and it sits right in there. So in terms of the hypothesis, considering that the majority of flow past the stented obstruction is extraluminal, we believe that the 3 French microstent may provide adequate drainage comparable to either a 3 or a 4.7 double J stent. And one of the other added benefits would be that a smaller size stent may improve patient tolerability due to a lack of a renal coil. So we first tested this in an in vitro ureter model and essentially found that the 3 French microstent drained better than a 3 French double J stent. And again, this is in the presence of an obstruction by a ball bearing. And it actually also drained very similarly to the 4.7 French double J stent. We then moved on to actually test this in ex vivo porcine urinary systems, again obstructed with a 5mm ball bearing, and found similar results in that the 3 French microstent drained better than the double J stent and very similarly to the 4.7 French double J stent, which was very, very encouraging. So I mean, one of the questions that of course arose is why is this, and we did notice that the micro stent does potentially increase flow due to the tenting effect that it has just proximal to the stone, creating a significantly larger space for urine to flow past the stone compared to just a normal 3 French double J stent. So of course the big question that arises is, how is this going to work in humans? And especially, is entirely extraluminal flow sufficient for drainage to decrease hydronephrosis? And the other question too is, what's the effect of the film anchoring device that essentially does push on the ureteral walls? And we are currently doing a clinical trial using this microstent here, and this is essentially being done on patients with obstructing distal or proximal ureteral stones who cannot get treated immediately. So if you do come across any of these patients, please feel free to contact either Ben or Olga Arsovska to have them included in the trial. And essentially these patients will undergo flexible cystoscopy under local anesthetic, will have a microstent inserted, and then the drainage and of course resolution of hydronephrosis will be assessed over time until their treatment. I don't know, Ben, did you want to say anything about it? Anything else?
No, I think basically it's patients who either like litho is full or they've eaten and can't get litho that day. Like we obviously can't withhold treatment in order to put them in the study, but if for some reason, or it's later on in the day, we can basically just do this even in emerge where we just put a flexible cystoscope in and just insert that micro stent right through the scope and put it in. So ultimately, the thought is actually to place this into the office, actually, in the United States. So if patients have problems, you don't need fluoro for it. You basically just do it either through a rigid or flexible scope and get by the obstruction. So it'll be an interesting trial. And we basically want to see if their symptoms go down and also if the hydronephrosis resolves.
Here's actually an example of one of the patients who had an obstructing distal stone here, who then inserted the microstent in quite successfully. So you can see it bridging the stone quite nicely, and then the film anchor, excuse me, would be found just proximal to the stone. So the other novel technology that we've been working on, as Samir did mention this as well, is the biodegradable stent. And essentially, just to give you a general example, it basically consists of a rigid coil that's similar to a telephone cord, and essentially that degrades slower than the other coil materials or the mesh materials that cover it. And this is the outer covering there is actually a hydrophilic polymer. And essentially, the material at the proximal end, and the stent has more material on the proximal end compared to the distal end, and that's to facilitate controlled degradation of the stent from the distal to the proximal end and prevent it from sliding out too early. And over the years, we've been working with different generations of this particular stent, and we've now hopefully got the final generation, and the third generation of this one we recently tested in vivo in pigs, and have found that all the stents degraded within 28 days of placing them. The reason this was 90% is because one animal did have 3 small fragments left in the bladder, but that would have been readily passed, no problem with urination. In addition, we found that animals that were stented with the Ureteral stent had significantly less hydronephrosis compared to those that were stented with the normal Polaris stent. And we also found that the degree of inflammation in the upper ureter, the mid-ureter, the lower ureter, as well as the bladder was significantly less in the Ureteral stented animals compared to the Polaris stented animals. So this was certainly very encouraging results. And so, again, this stent dissolves anywhere between 2 to 4 weeks in a very predictable fashion, again, from the distal to the proximal end. And hopefully this will eliminate the problem of the forgotten stents, or at least decrease the incidence. In addition, we found less hydronephrosis and less inflammation, so potentially this will translate into less pain and discomfort felt by the patient. And, of course, both of these, as well as other characteristics, will be tested in a human trial, which we are about to start here at VGH using this particular stent. So with that, I thank you for your attention, and if there are any questions for Samir or myself, please go ahead.